My name is Scott Mash, and I'm the past president and HIE liaison for the Central and Southern Ohio HIMSS chapter. One of my responsibilities as a member of the CSOHIMSS board is the Lunch and Learn webinar series, and thank you all for attending today. The handouts are available. You can download the 3 handouts, which are this introductory slide deck, the CEU form, and then the slide deck from our presenter. Are all available right now within the GoToWebinar app, and they will also be posted to the CSOHIMSS website. If you go under Events and Education, down to Past Events, you will find links to the handouts and recordings from every one of these Lunch and Learn webinars we've ever had, and along with the slide decks from every CSOHIMSS event. And again, the recording of this webinar will be posted to the CSOHIMSS YouTube channel, which you can go to youtube.com and look for CSOHIMSS. If you would like to get in touch with the CSOHIMSS chapter, our website is csohio.himsschapter.org, and then you can email the president, or if you send to csohio.info, it goes to our president and a handful of our board members as well. We try to remain relatively active on social media, so like us on Facebook, follow us on Twitter, and join that LinkedIn group. That way you can stay in touch with us and receive announcements about upcoming webinars, upcoming events, and then just some general information about the chapter. We would like to thank our sponsors, because without our sponsors, we could not provide these educational and professional development opportunities. Our premier level sponsors are Cover My Meds, CA Technologies, Cisco, and Nutanix. Our elite level sponsors, OnBase Merge, DMI, Innovative Consulting Group, Obix Perinatal Systems, Blue Orange Compliance, Direct Consulting Associates, IQSG, Encore, Metasource, Spectrum Enterprise, RDI Corporation, and Tech Systems. We just had our advocacy event. Oh gosh, it was just last week, so we would like to thank those sponsors one more time for hosting an outstanding Advocacy Day event at the State House, where our focus was leveraging health information technology to have a positive impact on the infant mortality rate here in Ohio. Those Advocacy Day sponsors were eHealth Ohio, Chime, the Health Collaborative, Red Hat, NetSmart, CliniSync, the Northern Ohio HIMSS chapter, and the HIMSS Innovation Center up in Cleveland. I'd like to share some information on our upcoming events. The big one is our spring conference right around the corner, Friday, May 12th at the Conference Center at OCLC. We are talking about healthcare disruption. The Sin of Healthcare Disruption is the title of this event. You can go to the CSOHIMSS website to get the full agenda. There's a link over to the Eventbrite site where, again, there's another copy of the agenda, but you can also buy your ticket. We really believe this event's going to sell out, so jump over there now, buy your ticket. Outstanding speakers from across Ohio. We have folks, Ohio Health, Premier, UC Health, Wood County Hospital, Cardinal Health, and I know I'm forgetting a bunch of folks. So register for this event. It's going to be outstanding. We do have some upcoming Lunch and Learn webinars, and I do want to apologize. Here in the first part of the year, there were some that got rescheduled, that got bumped. We just took a while to get our feet under us to get these events rolling, but now we've got the schedule pretty much full, or at least it's coming along pretty well. Next month, May 10th, the topic or theme is going to be Next Gen Patient Engagement Using Mobility, Cloud, and Big Data. This will be presented by DMI. In June, John DiMaggio, the CEO of Blue Orange Compliance, will be doing a security risk analysis and HIPAA-related webinar. We don't quite have the topic and theme dialed in yet, but it's going to be right in HIPAA security review area. Scott Gaines from Cover My Meds will be our presenter for July. If you have a message you'd like to share, information about a project, contact me because we do have some open dates. August is our first open date. I think I might already have somebody penciled in for this one, but there's some dates later in the year. These webinars are a great way, if you are a HIMSS member, to get points towards membership advancement. There's different areas where you have to gather points. I myself, I am a HIMSS fellow. It takes a lot of work. You got a lot of points that you need to achieve, and one of those is presentations or articles or items like this. Presenting a chapter event counts towards that. September, we've got EHR integration. Again, we're working on the topic for this one. There's 2 or 3 we're kind of kicking around, but if you're interested in presenting, I will find a time for you. So now we are going to get to our main speaker for today. Give me just a second. Kim, I've got you unmuted and am now making you the presenter. You should see a pop-up to share your screen.
Can you see my screen?
Yes, ma'am. The floor is yours.
All right. Thank you so much for having me here today. I really appreciate the opportunity to share some of the stuff that HSAG has been working on with CMS and get some of the priorities now that kind of had some attention brought to this topic. So this is the agenda for today. I'd kind of like to tell you a little bit about Health Services Advisory Group, talk somewhat about CMS priorities, and then drill down into some specifics for Ohio Medicare needs, and then dive into the integration of behavioral and physical health, talk about some of the ways that that is being permeated through various contracts, talk about next steps, and then we can have a wrap-up session. So HSAG is a quality improvement organization for Medicare. CMS has quality improvement organizations throughout all 50 states and territories. And HSAG is Quinn QIO for Arizona, California, Florida, Ohio, and the U.S. Virgin Islands. The QIO program was reorganized back in 2014, and now we are more regionalized. Even though HSAG doesn't look like a region, we are a region. And we have about 25% of the nation's Medicare beneficiaries within our region. We've been doing this for over 35 years. And then just so you know that the Medicare QIO program is actually funded through the Medicare Trust Fund, and it is the largest federal program that's dedicated to improving healthcare quality at the community level. And this is kind of a map of where we are. So let's talk about CMS priorities first, with regards to the regulations that they've come out with and the funding mechanisms. So first and foremost, CMS is a health plan. They function as a health plan, they think like a health plan, and everything they do reflects this. They are accountable to Congress. They are called before Congress for every program that they fund. They have to show the results of all of their contractors that they have, including the Quinn QIO program. They have regulations, both federal level and within some states in particular. They have several funding mechanisms that they do. So as a part of HHS, Health and Human Services, they are given the authority to write regulations and to distribute funding. So one of those things that deals with our topic today is the Quinn QIO Behavioral Health Tax. Specifically, we're going to talk about screenings and how to bill for those screenings. And then we're going to talk about some of the other ways that CMS has funded contracts to deal with this integration of behavioral and physical health. We're going to talk about some of the Transforming Clinical Practice Initiative tasks and some of the macro tasks. You all are familiar, I know, with the Medicare Access and Cheap Rate Authorization Act, or NACRA, CMS has come up with a funding mechanism called the NACRA Quality Improvement Direct Technical Assistance Contract. Clean QIOs are funded to do some of this, and then there's this other separate funding for small, underserved, and rural providers. In addition, if we look at some of the alternative payment models, there's also this integration that we're going to discuss. So let's just have a quick review of the CMS regulations. So we have the Affordable Care Act, which I know is a hot topic right now again, but what it did was it supported emerging models of care delivery, including accountable care organizations that we lovingly refer to as ACOs, and patient-centered medical homes, or PCMH. It created financial incentives for providers, and it set new standards for quality of behavioral health care. And then in 2014, CMS also launched the Innovation Accelerator Program, or the IAP. That program support provided up to 10 states, Medicaid agencies, to expand or improve on physical and mental health integration specifically. And then there were also some federal grant programs, $1 billion awarded nationally to initiate coordinated service delivery. And actually, care coordination is also a very large part of our Clean QIO contract. If we just look at some of the state regulations, we can see that the Massachusetts Primary Care Payment Reform Initiative supports the delivery of primary care through patient-centered medical homes, which also are required to integrate behavioral health services. This was a $44 million award, and it was over 3.5 years, ended in 2016. We also have still in process the Colorado framework that created a system of clinic-based and public health supports to spur innovation with this integration. Provides access to integrated care and behavioral health services in coordinated community systems. And then the state of Colorado is receiving, I guess I should say, in the process of receiving $65 million from the Center for Medicare and Medicaid Innovation Center, or CMMI, and that is February 2015 up through January 2019. And then, of course, in Ohio, we have the Ohio Mental Health Transformation. It's the Ohio Medicaid and Mental Health and Addiction Services. They're restructuring all the Medicaid reimbursed behavioral health services under managed care. And they're exploring new ways to pay for behavioral health services that actually reward providers who improve outcomes and still hold down costs. And then Governor Kasich in Ohio's mental health expansion, can't talk today, sorry, bad day to give a speech. Governor Kasich targeted funding of about $1.5 million for mental health and addiction treatment that allowed expansion, here we go, of behavioral health services to 54 counties. The current budget runs through June, so it's about to end, and it bumps up the allocation to $2 million per year. Nearly 500,000 low-income Ohio adults receive mental health and addiction services under the state's Medicaid expansion, and about 100,000 of the new beneficiaries have severe mental illness, including psychosis, schizophrenia, and bipolar disorder. Of course, we all know that the opioid epidemic has hit Ohio fairly hard as well. So let's talk about, for a minute, some of the work that's going on in Ohio with integrating mental and physical health. So one of the things that we've been working with quite a few providers, we have about 230 provider practices that we're working with on this task. If you want to be one of them, let me know. We can pull you in. But we are working with primary care providers in depression and alcohol use disorder, on how to recognize that, how to screen for that. We're looking to improve the quality of care specifically for Medicare patients by increasing these screenings. Practices can receive full Medicare reimbursement if they utilize the proper codes for screening. It can be done with the annual wellness exam. There's G codes that we work with the practices and learning how to use those G codes, when to screen, when you can bill, when you can't bill. For it, we have other kinds of flyers that are out there. We try to address issues as they've arisen. For instance, because we have national calls with a national coordinating center, one of several other states had mentioned that the fiscal intermediary, or the MAC, Medicare Administrative Contractor, started rejecting these codes and the claims when they saw an uptick that was not in the practice's regular billing activities. Although we did not experience that in Ohio, we went ahead as a Clean QIO group and had calls with our MACs about this issue to let them know that we're working with providers and they're going to see it. It does not necessarily mean that they need to be audited, because it's another CMS contract that we're working on, so we did that. And then we did have a few providers within our own QUIN that expressed concern that patients would look at their EOBs and say, why are you screening me for alcohol misuse? Well, why are you screening for me for depression? Because it does show up on the EOBs. So we created a flyer that providers can hand out to their patients during their annual wellness exam that explains that these two additional screenings in particular are part of their preventative wellness exam, and they're supposed to be part of the wellness exam. So we've tried to hit any barrier that has come about so that our providers, especially our primary care providers, can be screening for these things. In addition, we're also looking at working with inpatient psychiatric facilities and working to reduce those readmissions for mental health disorders. Just so you know, we're trying to coordinate that care as well. And then, because we work for Medicare, we are also helping to provide technical assistance for implementation of the quality payment program. That is part of our regular task. Previous to the quality payment program, we worked with providers all over the state on PQRS, and the physician quality reporting system, and being able to download their QRUR and put into place quality improvement interventions so that they could raise their score, not be hit so hard by volume-based modifier and things like that. So we are working with practices still on the quality payment program on very similar activities. If you look at the quality payment program, one of the performance categories is the improvement activities. Used to be clinical practice improvement activities, or CPIAs, and now it is just cause improvement activities. But some of the ones that address specifically behavioral and mental health with physical health is offering integrated behavioral health services to support patients with behavioral health needs, dementia, and poorly controlled chronic conditions like diabetes and depression go hand in hand, COPD, heart failure, things like that. Another activity is integration, facilitation, and promotion of the co-location of mental health services in primary and or non-primary care clinical settings. So I know some FQHCs, or federally qualified health centers, have done this as a test model over the years. Sometimes works very well. And then another one is diabetes screening for people with schizophrenia or bipolar disease who are using antipsychotic medication. I think we've all experienced the impact of not sharing just even medications across, and really doing that medication reconciliation, and including behavioral health aspect in those types of medications as well. So we're seeing that this is clearly a priority for Medicare, not just the depression, but also the alcohol and substance abuse disorders. And tobacco. Tobacco use is also an activity that you can attest to. Of course, these are only 10 points apiece, but you have quite a few to choose from that deal with integrating physical and behavioral health. So tobacco use is one of them. Unhealthy alcohol use is one of them. So really having regular engagement with your physicians, including the screening and brief counseling for patients with those co-occurring conditions, and then making enhancements to your EHR to capture additional data on behavioral health populations and actually use that data for additional decision-making purposes, like capturing additional behavioral health data results and additional depression screening for at-risk patients that were not previously identified. And just a few more is the depression screening that we talked about and a follow-up plan. Having regular engagement of the clinicians or groups in integrated prevention and treatment interventions, including screening, depression screening and follow-up plans for patients with co-occurring conditions. And then just major depressive disorder, having them integrate prevention and treatment interventions, including suicide risk assessment for mental health patients with co-occurring conditions and behavioral and mental health conditions. But the advancing care information also has some behavioral health issues in here. Again, to be able to integrate this whole thing, an ACI objective is coordination of care. It's huge through patient engagement, which includes the view, download, and transmit and secure messaging, and then just patient-generated health data. Those are all critical in that coordinated care between physical and mental health and behavioral health, especially that medication. Can't emphasize that enough. And of course, in addition, we have quality measures. So that's 3 of the performance categories that you can actually impact and choose to work on integrating physical and behavioral health. Of course, quality measures is the highest weighted performance category in 2017. And I don't want to turn this into a QPP presentation and explaining all the differences between the performance categories, but this one is weighted about 60% of your overall score in 2017 should you choose to fully participate. So these are just some quality measures that eligible clinicians can choose from that focus on this. It's the screening for clinical depression and follow-up plan. Again, the unhealthy alcohol use, screening and group counseling, those are all billable for Medicare fee-for-service patients. Follow-up after hospitalization for mental illness, and also the depression utilization of the PHQ-9 tool. That tool is built in to a lot of EHRs, Epic, EMDs, Clinical Works. There's quite a few that have put this in as part of the documentation. Another quality measure is adult major depressive disorder, the coordination of care of patients with specific comorbid conditions. And then this is another funding mechanism that came up last year, started last year, and that's the Transforming Clinical Practices Initiative, or TCPI. The QIO was funded I think it was last year, it might have been in 2015. It seemed that it took a while to come out and actually be awarded and implemented, but basically the practice transformation networks were awarded under the TCPI funding, and then the Quinn QIOs were assigned a task within our QIO to assess the practice transformation practices. So we provide a continuous process of assessing the procedures in a physician practice that is enrolled in this program to support quality improvement and patient-centered care. We have to deliver an assessment or walk practices through CMS developed assessment tool. We've conducted baselines throughout 2016, and now we're doing 6-month follow-ups on all the practices that the practice transformation networks have recruited. And it is rife with behavioral health implications. So one of the milestones, well, 3 of the milestones I listed here, and this is just 3 of them, but they are that the practice has to rate basically on a Likert scale between 1 and 5 how they've reached this milestone. So the milestone is that the practice provides care management for patients at highest risk of hospitalizations and or complications and has a standard approach to documentation. And within this milestone, they include behavioral health, hospitalizations, and then having a standard approach to documentation. Milestone 11 is that the practice facilitates referrals to appropriate community resources, including community organizations and agencies, as well as direct care providers. And some of these agencies that they mention are behavioral health agencies, behavioral health community organizations, also they reference things like safe houses for abused women, food banks, things like that. Those are all community organizations that take care of behavioral health as well as physical health. Milestone 15 on the tool is that the practice ensures that the care that they provide addresses the whole person, including mental and physical health. So let's dive into Ohio now specifically. The overall population in Ohio is projected to grow from, obviously, from 2010 to 2030. That's when you've got your baby boomers are now have been hitting for a little bit, the Medicare age. In 2015, the 60-plus population was 2.6 million, and it's forecasted to grow to 3.3 million in 2030. In 2010, 1 in 7 Ohioans were a senior compared to 1 in 8 Americans. In 2030, 1 in 4 Ohioans are estimated to be a senior compared to 1 in 5 Americans. So in Ohio, we're really seeing that trend too. You guys, Ohio, we have a whole lot of baby boomers that are entering into Medicare, which is one of the reasons, by the way, that we've enacted the Affordable Care Act, is to try and the quality payment program is we have to get a handle on our spending on the Medicare population because we've provided such good care that seniors are living longer and longer and longer, and the money that they have been putting away into the Medicare fund, they outspent. So that's another reason why we're doing this, which makes sense. So we have claims in, the Quinn QIOs have access to claims for 2014 and 2015. In 2014 specifically, there were 1,639,270 Medicare fee-for-service beneficiaries in provider practices across Ohio. And the reason that I pull out fee-for-service is because that's really the target population that the Quinn QIO is dealing and that we have claims information for. It does not include all of the Medicare Advantage plan beneficiaries. So this is just the fee-for-service, which excludes the Advantage plan patients. So CMS data indicate that for Ohio, for the fee-for-service beneficiaries, there were only 1.8 screened for depression that we can tell from the claims. And only 0.1 were screened for alcohol misuse. So basically what that means for the providers who have taken care of these fee-for-service beneficiaries lost over $56 million in revenue that they could have collected had they billed for it. Had they done it and billed, because we know that some of them are actually performing the screening, but they're not billing for it. So this is the TCPI initiative that I told you about earlier. They are paid to work with practices that aren't necessarily just Medicare practices. So these are the 5 phases that CMS has identified that takes the practice to be able to participate in an alternative payment model in QPP. These are the same phases that the Claim QIOs have been working with over the past 15 years with Medicare providers specifically. But now CMS is broadening it out to a broader base of practices, if you will. They're working with FQHCs, rural health clinics, Medicaid practices, Medicaid service practices, to take them through this 5-phase transformation so that they can truly be what the quality payment program, what their goal is, which is the alternative payment model. So first you have to be able to set your goals, then you have to be able to capture the data, report around those aims and the goals, then you have to be actually able to use the data in a meaningful way, like meaningful is, to actually achieve your goals. So they said you have to set your goals, collect the data, make progress on the aims and the goals, then be able to achieve what's called benchmark status. Benchmarks are typically set by Medicare. I do have the 2017 benchmarks that are available if anybody is curious as to what they are. And then thrive as a business via a pay-for-value approach. And these are the TCPI goals. They are working with close to 150,000 clinicians in their networks. They are supposed to help improve the health outcomes of the beneficiaries for Medicare, Medicaid, and CHIP beneficiaries, as well as private patients. They have a goal similar to the Claim QIO in reducing unnecessary hospitalizations. And also there is the Hospital Innovative Network, Hospital Innovative Improvement Network, or the HIMSS, H-I-M-N, that the Claim QIOs are in some of the HIMSS, and then there's some other HIMSS. Ohio has a couple of different HIMSS that they work with, but they have that same goal. So Medicare has a lot of money going towards reducing unnecessary hospitalizations. And then they're also to generate between $1 and $4 billion in savings to the federal government and commercial payers. Some of that is through the unnecessary hospitalizations. Some of it is through the unnecessary testing that they list below. They have to come up with actual measures and interventions that will allow them to target specific unnecessary testing, such as MRIs for headaches, repeat HbA1cs, things like that. And then to really build the evidence base on practice transformation so that we can scale some of those interventions for reducing the cost. Right now there are 29 PTNs. They're supposed to be peer-based learning networks designed to coach, mentor, and assist clinicians in developing core competencies specific to practice transformation. The main metrics, again, are the readmissions, admissions, unnecessary testing, implementing successfully quality measures, and improving efficiencies. And one of those improving quality measures, they are also required to pick a standardized quality improvement technique, such as Land Use Study Act, any kind of lean methodologies, things like that. In Ohio, there are 4 PTNs. The Great Lakes PTN is a combination of contracts between Indiana University, Alterum, and Medical Advantage Group. Medical Advantage Group, they are the ones that are on the ground providing the technical assistance. And then there is the National Rural Accountable Care Consortium, which is also known as Caravan now. They have a handful of practices in Ohio that they're working with. Then Vizient is working with a whole lot of providers in Ohio. They target the large academic medical centers. And then there's COSEC, which is mainly is a consortium of southeastern states in the United States. I believe they only have one practice in Ohio, but they do have a presence, and I'm sure that they will appreciate more. They have focused, they were a healthcare consortium before the PTN program came out, and they did a lot of work in their consortium on hypertension. They target that specifically, and they have a data warehouse that collects hypertensive data. And then, of course, we have the MACRA, Quality Improvement Direct Technical Assistance. That is also a big pot of money that CMS has distributed, known as the QPP SERS. And they provide support for practices who have 15 or less eligible clinicians, particularly in under-resourced areas, such as the health professional shortage areas, rural areas, or even urban areas that are medically underserved areas. The aims of this contract are to offer multiple pathways with varying levels of risk and reward for clinicians to tie more of their payments to value. It also expands opportunities for a broad range of clinicians to participate in alternative payment models. Ohio has the CPC Plus, or the Comprehensive Primary Care Plus, and I know there's a lot of clinicians, especially down in Southern Ohio, that participate in that. That is an advanced alternative payment model that excludes you from NIPS. Very nice deal there. Also, the state was given, through the State Innovation Model grant in other areas here, the Ohio Medicaid has a CPC program that we're working on, which is just the Comprehensive Primary Care, and it is a PCMH model, which is an advanced alternative payment model. So the goal is to minimize any additional reporting burdens for eligible clinicians and to promote understanding of each clinician's status with respect to NIPS and or APMs, and to support a multi-payer initiative in the development of APMs in Medicaid, Medicare Advantage, and other payer arrangements. So in about 2021, Medicaid will be, as a whole, as a nation, will be coming out with some alternative payment model choices, and I know that they're going to look to Ohio to get some best practices and model. And that is all that I have today. It's about 12:40. If anybody has any questions, I'd be happy to answer them at this time.
All right, let me pull up the questions here real quick, Kim.
Do you want me to?
First,
you want to take the screen back?
We can just leave the your contact info up there for a little bit. So.
Okay.
So, first question is, how does the integration of behavioral health, as mentioned in your presentation, overlap with the CPC Plus Track 2 behavioral health requirement?
Oh, it definitely overlaps. The CPC Plus program, one of the things to keep in mind is when you hear the words alternative payment program, especially an advanced alternative payment program, it means that they're exempt from NIPS, but it doesn't mean that they're not doing NIPS already. So while CPC Plus has that component built in, it meets the requirements. And you see, typically the advanced payment models are exceeding and measuring some of those same things. So there's a lot of overlap.
Okay, next question. Is there a charge for the HSAG services or assistance with areas or programs mentioned during your presentation?
No, we are subsidized by Medicare to work with providers and provide them technical assistance at no cost to them.
Okay, let me check one other spot. I think that's all of our questions, Kim. I'd like to thank you so much for presenting today and serving as one of the CSOHIMSS Lunch and Learn speakers. Very, very much appreciated.
Well, I appreciate you giving me the opportunity and for the callers for calling in, because this is such a hot topic now, and there is a lot of money coming out from our government for us to work on this and make it better. So I'm very appreciative for people that are interested in the topic and diving in. So thank you very much, Scott. I appreciate it.
All right. Well, thank you to all the attendees. For those that did not download the handouts, we'll get those up on the CSOHIMSS webpage very soon, and we'll get this recording posted to the CSOHIMSS website. Again, thank you all for attending, and we'll catch you next month.